I'm Dr. Dave. Thanks for joining me. I got my scrubs on because today we're talking about surgery for sigmoid diverticulitis, also known as sigmoid resection, or more formally, sigmoid colectomy. Sigmoid referring to that part of the colon which we're removing, and when ectomy is at the end of a word, it means surgical resection of that part of the body. So colon, ectomy, colectomy. Now, I'm not going to be talking about diverticulosis or diverticulitis because I cover that in my other videos, so please look for those if you want to learn more about those topics. But today we're focusing on sigmoid colectomy for diverticulitis for patients that were either told they need the surgery and or patients that want to learn more about it. Okay, so for the majority of this video, I'm going to explain how I perform this operation. Now, there's different types of approaches, and I'm going to go over them and which one I choose and why. Even if the surgeon that you chose does not use my approach, remember, the procedure is pretty much the same, so this video will hopefully help you understand how we perform the operation. Now, I'm not going to show you any live footage from the operating room in this video because I realize not everybody wants to see that. But if you do, please check out my other videos that show footage from the operating room. Now, I'm also going to go over some of the most common questions that patients ask me that are going to have this operation. So if you have questions, hopefully you see that on that list. I'm a colorectal surgeon. I work in Denver, Colorado. I work with Denver colorectal specialists. Please check us out on the web. I trained at the Mayo Clinic, and I've been in practice for 25 years. So please, scrub in with me, Dr. Dave, as we go over sigmoid colectomy for diverticulitis. So sigmoid diverticulitis is by far the most common type of diverticulitis that involves the intestinal tract. The basic premise of the surgery is really straightforward. All you need to do is go in and get out that piece of diseased colon, remove it, and reattach the two healthy ends. Now, up until 25 years ago, the surgery involved making a big incision up and down the abdomen, going in, removing that piece of bowel, and reattaching the two healthy ends. Great surgery. It left you with a big scar, fair amount of pain, and the recovery took several weeks. Then along came laparoscopic surgery, which was one of the first types of minimally invasive surgeries. This involved the surgeon making small incisions in the patient's abdomen and placing a camera and small instruments inside, performing the same operation. These small incisions meant less pain, quicker recovery, and quicker return back to normal activities for the patient. This was a great thing. So many of you may have heard about robotic surgery. So what's the difference between laparoscopic and robotic surgery? Well, they're both types of minimally invasive surgery. Laparoscopic, the surgeon is standing at the patient's bedside operating. With robotic surgery, the surgeon is at a console in the room with the patient, but controlling these instruments through the console. And the instruments have a little bit more functionality robotically than laparoscopic. I do both, so I can speak to both. And I can say initially we thought robotic was going to be even better and the patients would do better. But what we found is in most operations, especially with colon surgery, the results are pretty much the same. Pain, recovery, all those other factors. So how do we choose? Well, it depends on what operation I'm doing, depending on which approach I use. For this type of operation, for sigmoid diverticulitis, I can use 3 ports instead of 5, so less incisions, and the time for me is 1.5 usually in general versus the average nationally, which is 2.5, 3.5, sometimes even 4.5 robotically. So for this operation, I generally prefer to do it laparoscopically, but no matter which approach your surgeon chooses, whether it's laparoscopic or robotic, they're both minimally invasive surgeries, and that's the way to go. Okay, so the first question I usually get is how long does the surgery take? So for me, remember, I've been doing this a long time, 25 years. It generally takes about 90 minutes, start to finish, to get this operation completed. Now, it often depends on how diseased the colon is or how sick the patient is. Sometimes it's less, like an hour. Sometimes it's longer, like 2 hours, but rarely more than 2 hours. The next question I get asked is how much colon are you going to be removed? In general, it's somewhere between 8 to 12 inches, but this really depends on how diseased that section of bowel is. Remember, the colon's about 4 feet long, so removing this amount doesn't generally impact the long-term functionality of the colon. But to better understand why we need to remove that amount, let's review the surgery. So the basic premise of laparoscopic surgery is to create a cavity or space in the abdomen so that we can see and place instruments in there and perform the operation. In order to do that, I take a small needle just like this one here and place it through the skin, then the fat, then the muscle, into the abdominal cavity, and through that needle we can pass air into the abdominal cavity and expand it so we can create that cavity to work. Once we've created that cavity, we need a way to move instruments in and out of that cavity without air leaking out. So we take a device like this called the trocar, we place that through small incisions into the abdominal cavity, and that allows us to exchange instruments in and out and perform the operation safely. Instruments such as this, a grasper, and we use this through the trocar, and this allows us to grab tissue, manipulate it, so we can perform the operation. Another instrument that's very important is an energy device, and this is what's called the harmonic scalpel. When we take this harmonic scalpel, we can also place this through the trocar, and this allows us to grab vessels, seal them, divide them, and prevent any bleeding as we perform the operation. Very important. It's an amazing instrument. I'm going to talk to you a little bit more about what this does in just a second. Once the trocars are in place, the first instrument we have to put in is obviously the camera. We do that to look around and make sure there's no other issues, so we check all the organs, things such as the liver, the gallbladder, the stomach, the small intestines. Then we look for that piece of gum you swallowed in third grade that we know is still inside you. And I'm kidding. We never find any gum. That's gone. That's just an old wives' tale. Then we draw our attention to the disease section of sigmoid colon that we need to remove. There are attachments on the outside edge of that colon that are holding it in place, and we need to divide those. And we use that harmonic scalpel that I talked about earlier to divide those attachments. Now, not only those, but we also have to free up the attachments to the other part of the colon above so we can swing that down and reattach it to the healthy rectum. So we divide those up above at the descending colon, and then sometimes up around that bend in the colon by the spleen, appropriately called the splenic flexure. And once we feel like we've freed up enough of the colon to reattach it, we then have to take the blood vessels. This is one of the last steps to free up that colon. Those blood vessels keep the colon healthy, so we need to divide those. And we again use that harmonic scalpel with a different setting this time that will divide and seal those blood vessels at the same time. Pretty cool. Once we've done that, we're almost ready to remove the colon, but the last step we have to do is divide and seal those ends. So once we've mobilized the colon, we then have to divide it. And how do we do that? We use a stapler, right? Just like this. Well, not quite like this, but it's kind of like this, believe it or not. You have to get a special device that's going to fit through the trocar just like this. And this is long and skinny. It can fit through that trocar, and these jaws open. And once you're through there, you put the bowel in the jaw, you close it down, and this actually fires rows of staples and has a knife blade that cuts the bowel between those staples, so it's sealed and then divided all at the same time. Again, incredibly amazing instrument that we get to use in the operating room. So now let's take a close-up look at this stapler so you can see it in action. You're going to be blown away by how this thing functions. It's really cool. So here's a close-up of the head of the stapler. These tiny holes here are where the staples come out and seal the tissue. There are 6 rows of them. And the slot in the middle is where the knife blade comes out and cuts the tissue after it's been sealed. So there are 3 rows of staples on either side of the cut. So staplers have 2 parts. One side where the staples come out, and the other side called the anvil, which is made of metal. And this is where the staples hit, bend, and form to hold the tissue after they've gone through it. Now let's flip this over so we can see the inside of this anvil. Here you can see the pockets where the staples hit, bend, form to hold that tissue. Here's an animation of what staple formation looks like. Here are some formed staples, and this is an extreme close-up. These are really small. Now, to see the stapler in action, we have to remove the anvil. Keep in mind that this is a demonstration. This obviously wouldn't happen in real life, but we want to see how this works. So with no anvil, the staples are obviously going to fly all over the place. But in slow motion here, you can see the knife blade following closely behind the staples as they come out. You have to agree, this is some cool engineering. Let's put the anvil back on. Now I'm going to place a hollow bag which will simulate the bowel inside the jaws of the stapler, and I'm going to close it down and fire it across this bag. And you can see here the staples as they're being fired across this bag. I'm going to open this up and pull this bag out, and you can see those rows of staples fired right here, and the bag is sealed and cut. Now, to show you how well sealed it is, I'm going to pour some blue fluid in the bag, and you can see up close here the 3 rows of staples overlapping, and the fluid is staying within the bag and it's not leaking out. And this all happens within a matter of seconds. Some amazing engineering going on here. So this is how we seal and divide the bowel laparoscopically. So once we've safely divided and sealed that disease section of colon, we got to get it out of there. It's no good anymore. So we make a small incision, pull that piece of colon out through that, hand it off the field to the nurse, and they in turn send it to the pathologist. And over the next couple of days, they're going to check it out and make sure there's no other issues with it other than the diverticulitis. Now, we have to get those two healthy ends of bowel back together again. How do we do that? Well, this time we use another type of stapler, and this one is extra fancy. No, not that type of fancy. It's really cool though. This is what it looks like, and this is called a circular stapler. And this end actually comes apart. This is called the anvil. We're going to take this, we're going to put it inside the patient, and then sew it into the upstream piece of colon so that once it's in place, we're going to take this other end, put it up through the rectum. Don't ask how we do that. We just put it up through the rectum, and then by turning this knob here, we're going to open a spike on the end of it. And once this spike comes out through the rectal stump, we need to reattach the two pieces back together again. So we take the anvil like this, and we reattach it. Once it's clicked in place, we then close this by turning the knob the other way, and this pulls it all back together again. Once it's safely back together again, we're then going to fire the trigger right here. Okay, see that? And that's going to fire two circular rows of staples all the way around, and then a cylindrical knife blade is going to come and poke a hole between those staples and recreate that channel of colon so it's all back together again. So your breakfast, lunch, and dinner can all go safely through without any issues. That's really cool. So now let's take a closer look at this circular stapler in action. I think this is even cooler than the linear stapler, which I just showed you. Here is the head of the stapler, and you can see these holes where the staples come out, and hidden inside is the cylindrical knife blade that's going to come out and cut the tissue. Now I'm going to fire this, and without the anvil attached, again, the staples are going to fly out everywhere, but you're going to see how they come out and how the knife blade follows right behind them to cut the tissue. Now here's what the anvil looks like, and again, this is the metal piece that the staples hit and bend to seal the tissue. Now I'm going to attach this and fire the stapler, and you're going to see these staples come out and bend. Now they don't bend very much because if I close the anvil all the way, you won't be able to see anything. But in reality, it's going to be closed more than this. Now let's go back to our bag, which simulates our divided bowel without the blood or grossness. Remember, I'm going to take the open end of that bowel and place a suture around it, seen here, and then I'm going to take the anvil and place it up inside that bag, tie the suture around the stem so it's sealed tightly around it. Now let's go over to the other end of our bag, and this simulates the rectum, and I'm going to place the stapler up into this bag, and once it's inside, I'm going to open up the spike by turning the dial at the end of the stapler. This is going to open up, and then I'm going to take the anvil, attach it, and then turning this dial in the opposite direction, it's going to close it back down again. Once it's closed, I'm going to pull the trigger, fire the stapler. This is going to seal the bowel ends and then poke a hole in the middle. Now let's open up the stapler a little bit, and you can see the circular row of staples that's been formed. Now let's take that sealed bag, look right down the middle, and you can see here's the anastomosis with a circular row of staples. This is what it looks like in a patient shortly after we've created this anastomosis. And this is what it looks like several years later, and you can see the staples have been completely sealed over. You can't even see them. Now to demonstrate how this anastomosis looks in our bag, I'm going to take that blue water again and pour it right down the center of the bag. And here you can see it flows right through and is sealed. And that's how we create an anastomosis. When we fire the stapler in the operating room on bowel, the knife blade creates two small rings of tissue in the center that we call, believe it or not, donuts. We want to check these donuts and make sure they're thick and complete, and that is one way that we can tell that we have a good solid anastomosis. One last thing we want to do before we're done is check that anastomosis and make sure there's no leak. So we put some saline or water in the patient, overflow that anastomosis so it's underwater, put a scope up into the rectum, put some air up in, distend that bowel, and make sure there's no bubbling or leakage, and make sure it's airtight. Once we're satisfied that that is sealed and not leaking, we close the incisions, wake the patient up, and bring him to the recovery room. We have successfully completed a laparoscopic sigmoid colectomy. All right, now that you know how the operation is performed, before we wrap up this video, let's get back to some of those questions that patients ask me before they have the surgery. The next question, and this is a big one, almost every patient asks me, will I need a colostomy? If you don't know what that is, a colostomy is when you pull an end of the intestines up through the skin and muscle sew it to the skin edge so that everything you eat, all that waste, comes out of you and empties into a bag that's attached to your abdominal wall. Now, this is not something that anybody or most people want, and the good news is the vast majority of the time, patients don't need it with this operation when it's performed electively, meaning we've planned it. If a patient has to go emergently to the operating room, say they show up in the emergency room and are really sick and have to go right up to surgery, then they may need to get one temporarily. But the good news for that is if you have to get a temporary colostomy bag, usually I can reverse it within 6 to 12 weeks after the operation. Okay, so next question. How much pain will someone be in after this surgery? Well, most patients have some discomfort when they wake up, but this usually goes away fairly quickly, and within 24 hours, most patients are off any strong pain meds, usually just on Tylenol or Motrin, and when they go home, they don't usually require anything other than those medications, and usually within a week or so, they can get off that. Which brings us to our next question. How long will someone be in the hospital after this surgery? Well, most patients are able to go home the next day, or certainly by 48 hours. It's uncommon that patients have to stay beyond that, but we never push anyone out the door if they don't feel ready. But most patients want to get home to their own bed, to their own food. So I'd say 24, maybe 48 hours in the hospital after the surgery. So what should you expect in the way of recovery? Well, initially, most patients can get up and start walking that first day after surgery, but certainly by the next day, we want them up and walking a fair amount. As far as diet, you can eat solid food that day, but most people kind of stick to liquids because they feel a little nauseous or they're sore. But by that evening or by the next day, they can move on to solid foods. For restrictions, I generally recommend staying away from high fiber foods like raw fruits and vegetables for about a week, as it can give you some discomfort. But after that, you can pretty much eat anything you want. As far as going back to work, some people I've had go back to work within a week of the surgery, but most people need 2 to 3 weeks before going back to work, especially if they work in an office, because they're just tired from all of this. And so they find that they get really exhausted by around noontime. The only activity restrictions I tell people is don't lift anything over 10 pounds for about 6 weeks. You want those incisions and those muscles to heal over that time. Everything on the inside heals very quickly within 24 to 48 hours. It's the muscle really that we worry about. We don't want patients to develop a hernia. So we avoid that using your core for about 6 weeks. Another question I get from patients is, what will my bowel function be like after surgery? Well, initially things might be a little bit irregular, but over time, weeks to maybe 1 or 2 months, things generally get back to normal. Now, remember, the colon's main function is to 1, absorb water and recycle it from the waste, and 2 is to move that waste along until it exits the body. We have 4 feet of colon. We're removing just a fraction of that. So in general, the body adapts to that loss and things go back to normal. And then lastly, could I get diverticulitis again after the surgery? Well, the chances of getting it go way down, almost to 0, but not quite. I generally tell patients in my population, what I see in my patients is maybe 1% chance of recurrence over the next 5 to 10 years of developing diverticulitis, if it's done correctly. Remember, we have to get down to the top part of the rectum, so we remove all those pockets down to that point, but we don't always remove all the pockets. Sometimes patients have pockets all throughout their colon. We only remove it in the sigmoid colon, but it's important to get down to the bottom of the sigmoid colon, top of the rectum. And that way, the chance of you getting diverticulitis again is very small. Well, all right, that wraps up my video on surgery for sigmoid diverticulitis. If you're thinking about having this surgery, I hope this video helped answer any questions you might have and helped you better understand how the operation is performed. Now remember, I am a trained professional, so please do not try this operation at home. If you need this surgery, please see me or someone like me. And tell all your friends and family that you scrubbed in with Dr. Dave today and you learned all about laparoscopic surgery for sigmoid diverticulitis. And if you end up having this surgery, don't forget to ask your surgeon if they made 2 good donuts. And if you don't remember what that means, you got to go back and watch the video all over again. And if you have interest in any other colorectal issues, and honestly, who doesn't have interest in other colorectal issues? Please check out my other videos that talk about all the different topics that I see every day in my practice. Now, speaking about donuts, I have some unfinished business, so I look forward to seeing you at my next video.